Welcome, everyone. We're glad you have decided to join us for this webinar about supporting recovery from alcohol or drug addiction on campus, recovery high schools, and collegiate recovery programs. Our speakers today include Mr. Peter Gaumond, and he's going to be covering the importance of recovery support services and national drug control strategy. Then we have Mr. David Friedman, developmental perspective on recovery programs he'll be covering the biology behind addiction. And then we have Dr. Andy Finch. He'll do high school recovery programs, and Dr. Kitty Harris on collegiate recovery programs. This will leave us for time for questions at the end of the webinar. Please type your questions in the chat box on the right side of your screen. Peter Gaumond is our first speaker. He is the Chief Recovery Branch at the Office of National Drug Control Policy. Mr. Gaumond will speak about the importance of recovery and recovery support services, including educational support programs to achieve key goals on the National Drug Control Strategy. Go ahead, Peter.
Thank you, Carmen. It's a pleasure to have the opportunity to speak today, and I'm very much looking forward to hearing from our experts, Dr. Friedman, Dr. Finch, and Dr. Harris. I'd especially like to thank you, Carmen, and Bonnie Catone of Treatment Research Institute and the Addiction Studies Program and Wake Forest University for making this session possible today. And I'd like to thank everybody who is taking the time out of their day to connect and learn a little bit about this important topic. Before I get started in my talk, and one other thing I wanted to say before we move on is that Nora Sickert of the Department of Education had planned to be with us today in order to answer any questions specific to the Department of Education. Unfortunately, that's not possible. That turned out to be not possible. And so if you do have questions in that area, we'll certainly take those questions and then get back to Norris about those questions and try to get the information back to you. With that, Carmen, can we put up the first poll? So it seems, based on the input we have from probably a less than representative sample of participants, that we have at least 2 participants from the legislative branch and 4 from other areas. We'll try the second polling question, see if we can get more information. So at least based on this highly unscientific poll, 80% of participants are at least somewhat familiar with the National Drug Control Strategy, which is a good thing. So I'm going to move on. So the National Drug Control Strategy, as you may know, basically governs federal policy across many different agencies relating to drugs. That is, stopping their flow into the country, providing treatment, prevention strategies, supporting recovery, the whole sphere, everything from international activities to domestic activities. And one of the hallmarks of the National Drug Control Strategy under the Obama administration is a movement towards a balanced public health approach. That is not to say that there isn't a need for law enforcement. There is, and that is taking place. But that we need to look at this as a comprehensive, from a comprehensive perspective. As ONDCP Director Gil Kurlikowski, himself a former major city chief of police, once said, "We can't arrest our way out of this problem," meaning the drug problem. And so we need to have a really diverse portfolio that we take to address these issues. Under the current strategy, the priority areas include prevention, prescription drug abuse, which is, of course, climbing to epidemic proportions in parts of the country, and drugged driving, which is a growing problem nationally. Another thing that was unique about the Obama administration's drug control strategy is that for the first time it brought recovery into the center of the national discussion on drug and alcohol policy. Certainly it has been a concern prior to now and for many years, how do we support recovery? But this is the first time that it was part of the National Drug Control Strategy explicitly and is being systematically addressed. What does this mean? This means that we're looking at how we can change systems and services to better support recovery, to improve our long-term recovery outcomes. So it's not simply about, say, after treatment services. It's looking at everything from what happens before treatment, people who don't make it to treatment, and treatment itself, how we work with those systems to optimize the outcome. Also, we look at expanding access to recovery support services, which is really critical. Recovery support services are non-clinical services that can support individuals in long-term recovery. We tend to think of them as something that happens after treatment, say, and very often that's the case, but they can also be provided prior to treatment and very often can serve as a way of helping to engage people who may not be quite ready yet to take the step to go to treatment. They can also maintain engagement when there's a waiting list for treatment. And for some individuals, they actually provide a pathway in and of themselves to recovery, to long-term recovery. And so they can serve all these functions. They also serve the community more broadly and the family members of individuals in recovery. So they're kind of multifunction services, and very often they're provided out of what we call recovery community organizations, which are organizations, actually not-for-profit organizations that are established and headed by people in recovery themselves, and that do this expressly. Very often that involves volunteer work. It can be paid work as well, but it's always based on providing service to individuals who are in or seeking recovery. Another thing that we do that's important is identifying and addressing barriers to successful recovery. Very often, our own policies get in the way of what we want to accomplish, and some of the classic examples to that are challenges we encounter when we're trying to help people enter recovery, and they're encountering, say, barriers to employment, education, housing, professional licenses, and so forth, because of a drug-related conviction. And while we understand there's a legal basis for this, we also understand that, in effect, we're thwarting our own goal of helping that individual become a fully contributing member of the society, contributing to their community as well as they possibly can, and contributing to their family. And that's a challenge that we're addressing in many ways. There's a federal interagency reentry council that has done many things, one of which has created a series of mythbusters around what the restrictions truly are, because very often it's a misunderstanding of what is required that creates a barrier as much as the actual rules themselves. Recently, Attorney General Holder sent a letter to state attorneys general nationally, asking them to look at what are known as collateral consequences of convictions. These are related to drug concerns. These are provisions that go on top of whatever your sentence is, and they can be lifelong, that you can never do X, you can never participate in Y. And many of these represent barriers to recovery but don't serve an actual public safety function. So what the Attorney General Holder asked state attorneys general to do was to just look at these laws in their states and determine if there are ones that don't serve a public health function, because if they don't, it's probably best to explore the possibility of eliminating them and thereby eliminating unnecessary barriers to recovery in the community. So we have 4 overarching goals. I've pretty much addressed the first 3 of these already, and the 4th I've touched upon a little bit. In terms of establishing recovery as an organizing construct for demand reduction policy. Now, demand reduction policy, maybe I should define that term. The Office of National Drug Control Policy has 2 primary focuses. One is supply reduction, and that is activities designed to interrupt the flow of drugs to the United States, to arrest people who are distributing it, and so forth. That's the criminal justice and the internet and some of the international areas. Demand reduction is everything we do to prevent substance use, to treat it when it occurs, and to build strong, healthy communities. So that's the demand reduction side. And by establishing recovery as an organizing construct for demand reduction, we're doing something far more significant than saying having recovery support services would be a good thing. Yes, that is true, but what we're saying is when we look at how we do demand reduction, when we ask the questions, how best do we achieve our outcomes of improved public health and improved public safety, that we need to ask, one of the key questions we need to ask is how best can we support recovery in the community? And that extends to how we design services, what other services are made available, such as recovery supports, how we work with communities to create communities that are more supportive of recovery, and so forth. Secondly, it means developing measures, benchmarks, and quantifiable goals. And one of the challenges we have in the recovery domain is that there's very little research to date on that. So another priority of ours is to foster recovery research, ranging from developing valid and reliable consensus measures of recovery as distinguished from, say, a treatment outcome. And we can talk about that later. I don't have time to delve into that topic right now, but from that to evaluating various service models using recovery support services or various strategies for developing systems and services at the state or local level that are recovery oriented. And one of the things that we do a good bit of is partnering with states and local government to come up with solutions for some of these issues. And I'm going to go quickly through here. Some of the principles of recovery that kind of inform our perspective is that recovery is, in fact, a process. It's a transformative process, and it happens not only at the individual level, but at the family level, and even at the community level. And that as you build a strong recovering community within a community, you start to transform that community, to make it healthier and more resilient. And once you start doing that, you're starting to also meet some of your prevention goals. So that recovery is prevention not only in the sense that it may help prevent people from relapsing who are in recovery, but it helps create protective factors in the community, building a healthier, stronger community. Recovery is anchored in community and culture. So that's one of the reasons we focus on grassroots community-based organizations, recovery support services, to provide something that's flexible, can be culturally specific, can be provided over time, is cost-effective, it's anchored in the community. And we know that peers have a unique legitimacy and authenticity as mentors, guides, and coaches. And these are roles where they can be shown to be very effective. And finally, there are many pathways to recovery. So treatment isn't the only gateway. 12-step programs aren't the only mutual aid pathway. And what we see happening in the community and what we want to support is this development of a kind of overarching community of recovery where people follow in medication-assisted treatment, people following a 12-step pathway, people following a secular pathway such as a smart recovery, people following a faith-based pathway, maybe Celebrate Recovery, are all working together and speaking together as one voice and starting to support individuals in finding the pathway to recovery that's right for them. And I think with adolescents, this is particularly important. There's a common image of the young adolescent going to the AA meeting where there's 30, 40, 50, and 60-year-old people to whom he or she cannot relate in any way, shape, or form. There are young people's groups, and that's young people in AA groups, and that's a really important thing. But we need to provide a wide range of supports for our young people. And why a recovery strategy? I find this slide to be one of the most useful in kind of demonstrating the importance of having a recovery strategy. These data reflect the outcomes for individuals who completed treatment. So, and what the outcome is that when they interviewed the individuals who had 1 year or less of recovery at the time of the baseline interview, when they came back a year later to interview them, they found that only 36% had been able to remain abstinent throughout that period. Now, when they interviewed individuals who had already put together 1 to 3 years, they found that 2/3 remained abstinent for the next year. And when they went to the 4 to 7 year window, it went to 86%. Now, part of that may be sorting out individuals who are having difficulty, but we also know that a big part of it is getting across that first year. And that we know that when we provide the appropriate supports, a far higher percentage of individuals will be able to make it across that first year and into the subsequent years. And what does that mean? That means less cycling through the system, more available services, and in school, fewer public safety problems at school, fewer dropouts, better performance, better long-term outcomes. So, and I'm almost done with my slide share. I'm hoping not running over too far. And why support recovery in educational settings? And this is going to be covered far more in depth by the presenters that follow me. First of all, most substance use problems begin in adolescence. In fact, we know that if you can keep a person from using drugs or alcohol until they're in their 20s, their chances of developing a substance use disorder are extremely low. So this is an important factor. And then we also know that, especially among youth, when they exit treatment, very often a residential treatment setting, perhaps an outpatient setting, and they tend to return to school and have few, if any, resources there to really help support them in recovery, and they're back in the same milieu where they used in the first place. And so the outcomes tend not to be very good. So we need to have resources such as recovery high schools. And then finally, we know that we have to not only prevent drug use before it begins, but we also need to intervene earlier and more, because if we intervene while people are young, the individual, family, community, and national public health and public safety costs that could be avoided are enormous. And so it's critical that we do a better job of that. And part of that's going to be integrating services with primary care and broader health systems, and finding other points to engage people. And so with that, I'd like to thank you and hand the floor back over to Carmen.
Thank you very much, Peter. Now I welcome Dr. David Friedman from Wake Forest University and the co-director of the Addiction Studies in the States program. Dr. Friedman's presentation will be on the neurobiology of drug and alcohol addiction among adolescents and young adults. Go ahead, David.
Hi, everybody. It's really nice to be here and to be able to talk with you. The Addiction Studies program has as its goal to help states form better policies to deal with substance abuse issues. And we typically hold workshops for 4 states at a time to help do this. And we're delighted to be able to sponsor this program and participate in it to help with this issue as well. So I'm going to come, obviously, from a different perspective than Peter did, although you will hear that a lot of the issues that I mentioned and a lot of the things I say are just like what he said. And so the key points we want to keep in mind as we think about addiction is, first of all, it is a brain disorder. The evidence is now overwhelming that long-term drug use changes the brain. And the brain is very plastic and adapts to its environment readily, but reversing the effects of long-term drug use is a difficult, if not impossible, task. Another part of this equation is that drug addiction is learned. So a lot of the things, the behaviors that we see in addicts are things that they learned while becoming addicts. And the good news about that is that not that they can be unlearned, but new things can be learned in their place, which is really at the very basis of recovery. To echo what Peter said, addiction is a disease that largely begins in adolescence. To flesh that out some more, genetic factors are very important in determining who gets addicted, and environmental factors are also very important for determining who gets addicted. And so through the rest of the presentation, I will attempt to flesh out these points that I'm just made in this slide. So to start off, let's think about what addiction really is. and I think a useful way to do that is by comparing it to drug abuse. And the two columns here are pretty much way off against each other. So drug abuse, or heavy drug use, or drug use, whatever you want to call it, is basically a voluntary behavior. People who are users and abusers can stop and start whenever they want, with little difficulty. It may be somewhat difficult, but not so much. But the real definition of abuse is use that deviates from accepted norms. And of course, a classic example of this that we all know in young people is binge drinking. Addiction, on the other hand, is the loss of control of drug-taking behavior. Drug addicts cannot control their drug use. They have an overwhelming compulsion to take drugs. They spend a huge amount of time taking and recovering from drugs and searching for them. And when they can't get drugs, they crave the drugs that they're missing, in great distinction to abusers who don't have these cravings typically. Addicts also have an array of physical changes that go along with addiction and long-term drug use, including tolerance, which means you need more of the drug to get the same effects. Physical dependence, which simply means that the body adapts to having the drug on board, and when you take the drug away, we go into withdrawal, which is at best uncomfortable and at worst life-threatening. Addicts are also psychologically dependent on their drugs. They can't imagine living life without them, and find it exceptionally difficult to give them up for that reason. And abusers, on the other hand, don't necessarily have adverse consequences. They are, of course, open to all kinds of bad things that can happen, but these things don't necessarily happen, unlike addicts who's become tolerant, physically dependent, and psychologically dependent as a necessary outcome of their extensive drug use. The real problem with drug abuse is that it facilitates risky behavior, drunk driving, sharing needles, having sex, unprotected sex, and so forth. And all drug addicts were at one time drug abusers. So abuse is a very important risk factor for addiction. Under abusers, it simply says they can pretty much stop when they want. On the other hand, with addicts, it's important to recognize that addiction is a chronic relapsing disorder. People who become addicted essentially have basically a lifelong disease. While not everybody relapses, many people do, and it can be an expected part of the recovery process. But the issue of addiction being a chronic disease is a very important one and comes to the heart of why we need recovery communities. So just a couple of brief words on how genetics and the environment play into addiction. Environmental factors are often very crucial for determining how people get addicted. And there are a couple of, I have a list of them here that you can read, but there are a couple that are particularly important. One of them is early childhood stress and neglect. Especially among women, those who were abused and neglected as children have an incredibly high likelihood, or risk rather, of becoming addicted or at least abusers when they're adults. Another one, obviously, that I think is very important for young people is the influence of peer culture. And we all know that a lot of the behavior around drugs, especially alcohol, that we see in schools can disappear as soon as the people are out of that particular environment. But that's not always the case, and it is a risk factor for improper use of drugs and for addiction. In addition to that, genetic factors are incredibly important. We're becoming more and more aware of this. And the risk for addiction, the genetic risk for addiction, that is the genes that you carry into life, can account for up to 50 to 70% of the actual risk of addiction. And these genetic factors, it's not that there's a personality type or a genetic type that is, a drug abuser or a drug addict type. It's that there are certain predispositions that genes give you that will either protect you from drugs or make it more easily for you to become addiction. The rate of metabolism, for example, is a case in point. People who metabolize alcohol very rapidly are actually at much greater risk for addiction than those who metabolize it slowly. Peter made the point that addiction is a disease that largely begins in childhood and adolescence. And this graph, which was created by the National Institute on Alcoholism and Alcohol Abuse a number of years ago, shows the first time that the population they studied presented to treatment for cannabis use disorders. And what you see is an incredible spike between the ages of about 13 or 14 till about 20 years old. And then a gradual, not even a gradual, pretty sharp fall off of the curve to basically zero after that. So almost all the people who are presenting to treatment, because they got in trouble with pot, basically, are teenagers. And this same thing is true for all other kinds of drugs as well. Cigarettes, certainly most smokers start in adolescence, and marijuana, most users start in adolescence, and it's the same for many other drugs. So as Peter said, getting kids through adolescence is crucial in helping to protect them from drugs. And what this slide tells us is that we really need to focus our efforts very much on adolescence. Moving to the next slide, this simply is a couple of diagrams showing what happens to brain development during adolescence. And the basic problem with adolescent children is that, I guess all children are adolescents, is that their brains are not fully developed. And the picture on the left with the brains that go from green and red to brains that go to blue and purple shows the maturation of the cerebral cortex, the outer layer of the brain, which gives us our higher cognitive skills. And the maturation that takes place is actually a thinning of the cortex. That is, it loses neurons and connections as it becomes more mature and more effective. And it doesn't finish happening till 20 to 25 years of age. So adolescents, just because of their biology, have less cognitive abilities than adults. And the area in which these cognitive abilities are really weakest is in the kinds of things that are subserved by what we call the prefrontal cortex. Prefrontal cortex is the very front of the brain, and it's basically our decision maker. And it helps focus our attention, it helps us make choices, especially the kind of choices between, do I take a little reward now or a bigger reward later, which is often better, the bigger reward later. And so kids are just not good at making these choices. And what the panel on the right-hand side shows you is that what has developed more quickly is the so-called limbic system. And this is the system that, and that's the red line, the system that underlies our emotional feelings, our motivations, and our biological drives. And you can see that the red line rises far more sharply and reaches its plateau, the finishing of development, more quickly than does the prefrontal cortex, which is represented in the gray line. And so what we see in adolescence is a predominance of emotional decision-making over logical decision-making. As we move on to the next slide, we make the point that going back to the idea of addiction being a chronic relapsing disorder, addiction has traditionally been thought of as something that's completely unique and probably not even a disease, really. But the fact of the matter is that it is very much like other diseases that we know about. And it's like them in the sense shown in this slide. These diseases that are listed, hypertension, diabetes, atherosclerosis, are chronic relapsing disorders. They all begin with voluntary behaviors. Atherosclerosis, for example, by eating too much fatty food, not handling stress well, not having basically an unhealthy diet. They are exacerbated by genetic risk factors, which is why your doctor always asks about your family history when you go to visit, because what's happened to your family is an indicator of what might happen to you. They result in biological changes. So in the case of atherosclerosis, there are actually plaques that are laid down in your arteries. When people present for treatment, they're typically given medications in cases like this, because the medications can help stop or even in some cases reverse the changes, make the plaques smaller. And if you really want to recover, however, and have a long-term healthy life, what you really have to do is change your lifestyle. And so if we compare this to what we know about addiction, the parallels are very obvious. Addiction begins with voluntary behaviors, which is drug taking. There are genetic risk factors in play. Some people are simply more prone to becoming addicted than others, and perhaps we can say they shouldn't have used drugs in the first place, but once having started, you certainly can't select how your body will respond. And so those genetic risk factors play a big role in who might become addicted or who not. Addiction results eventually in biological changes in the brain, and I'll show you a couple examples of that in a moment. And medications can often be useful in treating addictions, although we have nowhere near the array of medications we wish we had. And finally, what addiction really is a behavioral disorder. And if you want to recover from addiction over the long term, what you really need to do is change your behavior, change your lifestyle. So keeping that in mind, lessons from chronic care models. The point is that we have learned a lot about how to treat chronic relapsing disorders with medical treatment. And the important points to make about it is none of these diseases have a cure. Although they don't have cures, we do have effective treatments, and that treatment can work. And this is certainly the same for addiction. We know that an important part of treating people for these kinds of diseases is keeping them in touch with the medical community, with their doctors and their healthcare providers, and that monitoring people with these kinds of diseases is crucial. And we know that in lots of patients, they're going to not take their medications, they're going to stop their diet, they're going to stop exercising, and that's so there's risk of relapses there, but it's predictable and it's preventable. And if we take that and translate it to addiction, we see perfect parallels between the two. So we know a lot about treating addiction from what we've learned in treating other diseases. An important distinction between addiction and the other diseases we discussed is that there's an important learning component to the addiction. There are what we call explicit memories. These are the things we can consciously recall, and all drug addicts talk about the wonderful times they had using drugs when they first started using. And then there are things we call implicit memories, which are forms of conditioning that happen unconsciously while we're using drugs. And these exert very powerful control over our behavior. And the important thing to keep in mind about drugs is that they activate a very important learning mechanism in the brain, something called operant conditioning. And the way that works is if you do something and you get rewarded for it, you're more likely to do it again. So if I do something nice for you and you say thank you, I'm more likely to do that nice thing again. It's how we train our children, it's how we train our dogs. It's a fundamental part of life, and it happens unconsciously. And when you think about drugs, it becomes apparent how this subverts our behavior, because drug use is incredibly rewarding. It produces powerful euphoria for most people, and that really reinforces the drug-taking behavior. So the more you take drugs, the more you're teaching yourself to take drugs. And undoing this is a really complex issue. So drugs activate this brain reward system far more powerfully than in anything else. And what you're seeing here are a couple of experiments that were done a number of years ago. And the key event that happens in reward and reinforcement is the release of a chemical called dopamine in the brain. You've probably all heard of dopamine. Many people call it the pleasure chemical. And what you see on the left is measurements from the brain of a rat who's sitting around, and you see the red line at 100%, and all of a sudden he's given food, and you see the level of dopamine in his brain jump 50%. So this is a perfect example of how reward works. And whatever the rat did to get the food will be reinforced, and he's likely to do it again. If you look at the right-hand panel, which is methamphetamine, it's the same kind of experiment. The animal gets injection of methamphetamine instead of food this time. And if you look at that graph and look at the scale, you see that the increase in dopamine in the brain is 1,000%, far more potent than food. In fact, the very small red curve you see at the bottom is the food response that's on the left side of the screen. And so the point of this slide is that drugs powerfully activate the brain reward system, and they're powerful teachers and controllers of our behavior. So drugs have a variety of long-term effects, and most of them are not good, as you all well know. The use of drugs creates tolerance, which means you need to use a lot more of them to get the same effect. It creates physical dependence, which produces withdrawal. There's nothing necessarily wrong with physical dependence, but every time you go into withdrawal, you start craving drugs, and it's a powerful motivator to keep using drugs, and a strong determinant of relapse. People go into withdrawal, and the immediate, simple solution to withdrawal is to use more drug. Obviously, another long-term effect of drug use is addiction. In many people, they cause neuropsychiatric problems. There are alterations in brain structure and function, and then finally there's overt brain damage. The image you see on the right are of structures in the brain called dendrites, and these are designed to receive information. And the one on the left is normal. The one on the right, you can see, has all kinds of additional little black blobs on it and misshapen blobs. And this is from an animal that had been given methamphetamine. So this is an actual structural change in nerve cells, neurons in the brain, that's caused by long-term drug use. And so one of the issues with addiction is we know that even in people who've been drug-free for a long time, there's a risk of relapse. And when we ask why might this happen, the answer to a neuroscientist is there must be something that's changed in the brain that stays changed even when drug use is stopped. And what we see here are images from the brains of monkeys who have been exposed to cocaine and looking at dopamine receptors. And so those two bright yellow blobs you see on the left hand of the three panels there, of the three images there, is a normal monkey who's never had cocaine, and the yellow indicates he has lots of dopamine receptors. The middle image is a monkey that had been, in fact, it's the same monkey, a year after he had been using cocaine. So he's using cocaine for a year, and now he's been abstinent for 3 days. And you can see, because the yellow blob is gone, that the number of dopamine receptors is way down. There are far fewer dopamine receptors in the animal's brain now than before he used cocaine. And finally, on the right-hand side is the same animal, 2/3 of a year later, 9 months later, and you can see there's a small amount of recovery in dopamine receptors, a little bit of yellow in there with the red. And so this is a great example of a change produced by drugs that doesn't go away even long after the drug use has stopped. And one of the reasons why recovery is so difficult. I would note, however, that in some other animals there's much more recovery. And it may be that how well dopamine receptors recover would indicate how well patients are able to recover. This is an example of craving in the brain. I'm going to skip over it, but what it shows is that there are specific structures in the brain that are involved in craving. And so when we think about recovery from addiction, there's a number of things that have to happen. Obviously, the person has to be gotten off drugs safely, and that's the role of detoxification. Then we need treatment, which is typically some form of behavioral therapy. And we find ourselves in the unusual position of having to treat what is essentially a brain disease with a treatment that's basically taught. Obviously, it's going to take a long time. It's going to be difficult to do. And what it requires is new learning. Learning of new behaviors, learning of new responses, learning of a new way to do things. And that is why support communities are so important in recovery because they reinforce this learning and put the person in a context where healthy behavior is valued more than drug-using behavior, and so is important for long-term well-being. As we've learned from other diseases, that people who fall out of contact with the treatment community, with the healthcare providers, are likely to relapse in other diseases like diabetes and atherosclerosis. So too are people likely to relapse if they have no contact with any kind of treatment community as they're trying to recover from addiction. And so that's a biological basis for why recovery communities are so important in treating addiction. Thank you.
Thank you very much, David. Next we have Dr. Finch from Vanderbilt University, and he will present his initial findings from a NIDA-funded evaluation of recovery high schools. Take it away, Andy.
Thank you, and I'm really glad to be here today talking to you all. I will tell you that the talk I'm going to give today is going to focus mainly on recovery high school settings and introduce the study that was mentioned. We are in the first few months of that study, so I actually don't really have findings to report just yet, but it is an exciting opportunity to finally have some research of this level of rigor to help us understand recovery high schools. Basically, want to introduce the recovery programs in secondary school settings. First question is just to find out what familiarity people have with recovery schools. So it seems like the majority of folks have actually heard of either recovery high schools or collegiate recovery communities, but don't know much about them, so I guess you're in the right place. Next polling question, please, just to see which of these you are most associated with, either high schools or colleges or both, for those of you that do know something about them. Okay, so pretty even split. Looks like maybe a little bit more familiarity of the collegiate recovery community. I will not be talking about those today. Dr. Kitty Harris will be walking you through the description of those programs, and I will dive into talking about the high schools. My first slide talks about risk factors, the risk factors that are associated with alcohol and drug use, and I think the prior presentation really set this up well for what we've learned in recovery high schools for teenagers, that things like drug-using peers, availability of drugs, academic challenges, and such are all things that are risky for a person to become dependent upon substances. And when we think about how often teenagers will use with peers that they go to school with, or even in that school setting, we can see how schools themselves are risky settings for students. Now, the next slide discusses the chronic nature. And again, in the prior presentation, this was set up very well, that we really learned that addiction is a chronic rather than acute issue. Now, some of you may be saying, well, I've always thought it was a chronic issue. I've always thought of this as a disease. But I would argue we often think of the disease of addiction as one that has been treated as an acute problem, something that one can go to treatment and get the help one needs, and then with a little bit of aftercare here or there, you're pretty much okay, as long as you maybe have some type of 12-step support here and there for the rest of your life, treatment should pretty much take care of it. And I think certainly what we've learned about the brain, and I think especially the slide on the monkey that had been exposed to cocaine, you can see that at best this is something that's going to take an awful long time, and likely it's going to involve numerous episodes of recovery, relapse, probably repeated treatment. And this quote sums that up from Dennis and Scott a few years back, that relapse and repeated treatments are really the norm, and the environmental factors that step in after treatment are really going to help to determine the success, especially for someone who started using very young in life. Now, when we think about traditional school-based services, we know that there are a variety of different ways that teenagers do get help in their school setting. And these include school-based health centers, linked services with maybe family resource centers, something called full-service schools that tries to bring treatment into the setting. All of these things on this list are ways that traditionally students have been served in a high school setting. Student assistance has often been more prevention-based. Area learning centers are something that Minnesota has had in the alternative school setting to try to address this. But on this list, the area learning centers and the alternative schools are really the only place where someone might go to get a different type of school setting. And for the most part, those aren't exclusively focused on alcohol and drug issues. The schools and recovery process over time, we can see that by not focusing on substance abuse exclusively, we still leave students at risk of being around people who are using drugs, especially in an alternative school where oftentimes people have been sent to alternative schools because of things they've done, either on drugs, selling drugs, or because the drugs they've used have caused them to act out in certain ways. And you can see this quote from a CASA study a few years back, that students who say they attend drug-infected schools are almost 3 times likelier to be able to get marijuana in an hour and twice as likely to be able to get prescription drugs in an hour. And then we see about 2/3 of high school students say that drugs are used, kept, or sold on the grounds of their schools. So we can see that someone trying to stop using is going to be confronted by alcohol and drugs in their setting with a real inability to change that setting unless there is an option for them schooling-wise. And when we look at a lot of the schools that students may have as options, we may find that the drug availability is even worse than in their prior school. So it is a very tough circumstance for teenagers in that way. The next slide looks at what we've considered protective factors to be for teenagers. And these are numerous studies, and these should be pretty common sense to folks. School bonding, academic achievement, succeeding academically, connecting with the school, having interest in school, all of these things will play into a person really engaging with their school setting and hopefully then engaging with the peers that are in that school setting and with the adults that are in that school setting. To the extent that those peers are using, this becomes less of a protective factor for someone who's trying not to use. Again, common sense would say that is the case, and yet we've set up so few schools to help kids in this way, often saying, well, it's not the real world to set up a setting that doesn't have drugs in it. Well, I mean, that may be a sad comment on society, but the reality is if someone as a teenager is trying to learn pro-social behaviors, and creating a setting in which those behaviors are taught and reemphasized becomes critical in order to help their brain develop properly. The next slide shows a quote that actually came from a study on support networks with adolescents with chronic disease. Now, the chronic disease in this case wasn't addiction, but if we consider addiction to be a chronic disease, this fits to some extent, and I found it to be really well stated. Fellow sufferers are the best supporters. They know what they're talking about. They can understand my feelings. Again, these are teenagers saying things like this. So easy to understand others when you have the same kind of experiences. Sometimes you just don't need words. You can share your emotions and feelings by just being silent, or put your head on the other person's shoulder and cry. She knows. She understands why I'm crying. This is really a powerful thing about a school that might have a number of students in recovery themselves. At a certain point, the recovery itself kind of fades to the background, and people really do get to understand just how to be with other human beings without the addiction being the front and center thing. It's kind of a paradox when you think about schools identified as being recovery high schools. If you have everybody in the building who is in recovery, or every the student in the building that's in recovery, they don't have to focus so much on that. They can focus about going about being teenagers and learning how to have fun. The next slide discusses continuing care components, and this is from the Godleys, who have developed assertive continuing care as one evidence-based way of trying to help people after treatment. And a few years back, they listed continuing care components of programs. And when you look down this list, these are things that tend to be pretty available in recovery high school. Sufficient intensity, duration of contact, multiple life health domains being targeted, cultural socioeconomic realities of the person. The schools are very small, and so they're often able to focus on things like this. Encouraging family involvement to the extent that families want to be involved. The small setting and the nature of the program really does allow for families to be known and involved. Pro-social leisure habits, a focus on relapse prevention, and then cognitive behaviors and problem-solving skills that help to reduce cravings, etc. So on the next slide, we talk about actually the recovery high school environment. When you look at the recovery high schools that exist, there's about 25 operating in the United States. They are the high schools that offer credits towards a diploma, continuing care rather than primary treatment. For the most part, recovery high schools don't focus on primary treatment. Most of the students that are in the school have had at least one treatment episode, if not multiple ones. And so when they're enrolling students in recovery from substance use disorders, and they're voluntary rather than students being forced there, these are places where students can focus on the longer-term continuing care needs and relapse prevention. Most of the schools do not have predetermined lengths of stay. The students may stay anywhere from 30 days on up to 4 years. Plenty of students that have gone through these recovery high schools since the first one opened in 1987 have spent their entire high school career in a recovery high school. That's not the norm, however. Actually, if you were to look at a distribution, you're going to tend to see more of a skew towards, say, around the junior year, in part because that is the flow of how addiction tends to happen for teenagers. Some of the general characteristics of a recovery high school, again, these are things that were stated on the prior slide as well to some extent. Supporting recovery from substance abuse, evidence-based practices that are designed to meet or exceed federal, state, academic, social, emotional learning standards, offering credits towards a high school diploma, and offering services that help a person abstain from co-occurring disorders. And so you talk about programs that are really geared towards supporting recovery. The next one talks about promoting relationships among faculty and students. Again, the size of the school helps with this. Sensitive to cultural and gender differences, trained staff, trying to actively engage parents, and forming collaborative partnerships with local schools and treatment centers. I'm just going to mention these briefly because I know that we are short on time here today. There have been a couple of studies that have been done that have been more descriptive in nature. The first one was done by Dr. Paul Moberg in Albuquerque on a school that started in 1992. And they described much of what I had described about recovery schools, therapeutic in nature, and their findings show that these tended to have a pretty positive effect on the students and families involved. And enrollment actually was a lot less than they had planned. And this is something that for a lot of the first schools tended to be true. They had hoped to maybe have 500, 600 students. And in this case, they had a 200 capacity, but ended up with about 30 or 40 students at a time. And in part, this is because this tended to be the most workable number because of the severity of the needs that students have. They also found that they emphasized therapeutics and it had a fairly high per pupil cost. A study that I did with Dr. Moberg a few years later visited 17 schools across the country and looked at these areas of emphasis, different types of programming, the context, etc. And we surveyed about 321 students, about a few more males than females. If you look at the mean number of days in the schools, it's about 7.5 months was the mean number of days in the school, ranging anywhere from 0 on up to 4 years in the school. About 55% had a parent with a college degree. You can see again, this is going to be more upper to upper middle class. And some pretty impressive numbers again on self-report. And quite a few days abstinent. When you look at this slide, the blue indicates 90 days before they've received treatment, and days since enrolling in the school. And you can see since enrolling, very few days of use, alcohol drinking, etc. And 266 days actually was the mean number of days since using alcohol or drugs for the students who were surveyed. This essentially looks at some of the gain Q scales to show that the students in recovery schools, if anything, had comparable to more severe characteristics across these areas than in the CSAT adolescent treatment program. So they're not dealing with an easier, quote-unquote, population, but one that has severity at or above in depression, suicide, anxiety, etc. These next two slides really look at a continuum of services, really just highlight where the students in recovery schools tend to fall. At the top, more specialized programs, high-risk programs. That's the little red part at the top. And we can see that that would fit well with the continuum of substance abuse, about 10% of folks needing continuing care for dependence and such. That's pretty much the group that is served by recovery high school. And what we found in our initial study was that the continuum of services at recovery schools would run anywhere from primarily recovery or support to something that almost looked very much like treatment, even though they didn't say they were providing that, often depending upon the students who are enrolled in the school. You can imagine if you have a mean number of months in a school, about 7 months, that the turnover is pretty high. And so you may have times where most of the 30 to 40 students in your school have longer-term sobriety, and times where many, if not most, have very short-term sobriety. So the services that you provide might need to differ significantly depending upon that. And so the complexity of the student needs might drive whether this looks more like a treatment-type program or a recovery program, even though they all state being recovery support. Now, the study that we have just received funding for last summer that my colleagues are listed here on the screen, this is a study that will actually give us some glimpse into the first rigorous outcomes that we've known. The prior studies have been much more descriptive or evaluative, and we've got 6 recovery high schools and multiple treatment centers involved, focused in Minnesota because of the number of schools that have concentrated in that state over the years. And our questions in the study are these. Do recovery schools improve academic and behavior outcomes compared to treatment? And going back into traditional schools, we're enrolling students in treatment and then tracking them for a year post-treatment and seeing if their outcomes differ, if they've had exposure to recovery schools, if the length of time in a recovery school seems to matter, versus going into the traditional school system and seeing outcomes academically and behaviorally and emotionally, et cetera, if those differ significantly. We're also looking at cost and the types of students. Do we see that the difference is being driven by the programs or is it by the students themselves? And over time, this is a multiple-year study, we will see if some of these initial suggestions are true, that recovery schools do provide that level of support that leads to better outcomes. But even if they do, one could see recovery schools fitting into something that would be more of a continuum of services. Clearly, the recovery schools probably will not be the best thing for every student. And in some, if you look at a range, for some students, maybe going into a traditional school in which they just have the support of staff, like school counselors, will be sufficient. On the other end, being able to transfer into something that's much more pervasive, like a recovery school, in which they can attend and receive services all day, or something more in the middle, in which they can get some types of maybe a school-based mental health center that's within their school setting that might provide a different level of service. But I would think these would be the 3 types of things that would help the greatest number of students. And we're quite a ways from having this in place, but certainly we are getting closer. The places where you can get more information on recovery schools, this obviously was just a quick overview. And the Recovery Schools Conference is in Houston, and a couple of publications that also can give you some idea as well. Now I'm going to turn things over, I guess, to Kitty Harris to talk about the collegiate program.
Thank you, Andy. And last but not least, we will hear from Dr. Kitty Harris, an expert on collegiate programs and the director of the Texas Tech University Center for Studies on Addiction and Recovery and of the Texas Tech Collegiate Recovery Program. She will explain the various forms that collegiate recovery programs have taken and present what is currently known about their effectiveness. Kitty, would you like me to advance your slides for you?
That's fine, Carmen. That'll be great.
Okay. All right.
And we're going to go through this very quickly. We are out of time. And so I'm going to, Carmen, I'll probably have you just go at a fairly quick pace just to highlight some of the most important parts.
I will gladly keep up with you.
Okay, thanks. Okay, let's go. The overview, I'm not even going to talk about. We'll get right to the point. So you can go ahead, Carmen. Why are we here? Probably one of the biggest things that we're looking at today is the emerging adult population has grown rapidly. And you can move on to the next one, Carmen. I'm not going to go through these specific things, but I think if you go back and look at the slides that are posted, you'll find out that so many young adults are being treated for addictive disorders. Next one. One of the most important things that we find with emerging adults are the developmental issues, and I think you've heard this throughout the webinar, is that adolescents and young adults are struggle when it comes to not only chemicals but also the developmental issues that put them in a position where they really struggle to grasp recovery. And the next one, Carmen, is looking at some of the barriers to collegiate recovery, the lack of social support, the lack of peer support, a real sense of identity issues which are developmentally based in that population, and certainly academic and financial struggles. Many of these young adults, their parents have spent their college money on treatment. And the next one, Carmen, this just shows kind of the main areas of support that we focus on in terms of collegiate recovery communities, and those are emotional, affiliation, information, and instrumental. And the next one, Carmen, informational and emotional support are a lot about acceptance, a sense of assistance from the university, affiliation, being able to belong, and informational advice, suggestions, and access to support. The next one shows a little bit more specifically informational and emotional support and what those really mean and what they mean to students that are in recovery that are starting collegiate in the collegiate area. The next slide shows something that, again, we look at instrumental and affiliation support. What does it mean to belong, and what can you do to enhance that? The next slide refers to what Peter talked about is the real need for research on recovery. And we're part of a national collegiate recovery database, beginning to look at what is it that happens with these emerging adults and what does that look like on a college campus. The next slide and the next few slides talk a little bit about what we found out. I'm going to skip this qualitative data outcomes. You can read that. And then why if you'll look at this slide on why I like my collegiate recovery community, you'll find that the largest percentage is that sense of affiliation, a place to belong. If you know anything about adolescent development, you realize that one of the real needs developmentally is a sense to belong. And being on a college campus and not partaking of chemicals really begs the question of where do I belong? And the next slide is why I enrolled in my CRC, and again, highest in the level of affiliation, a place to belong. The next slide shows a little bit of the quantitative outcomes, and the two I would draw your attention to that I think speak volumes is that the average GPA of the students in this last year's data collection was 3.0, and that's a B average. It's higher than the majority of the GPAs for the universities in general, and the average length of sobriety is 3.3 years. And the next The next slide shows the survey outcomes, and two I would draw your attention to that I think are incredibly important. The first one is for the fall semester of 2011, Collegiate Recovery community students participating in the study had a 97% recovery rate. And those of you that are involved in recovery know that's just about unheard of. And if I hadn't seen the data myself, I'm not sure I would have believed it. The other thing I think that's really important is the second outcome that we noticed, that 83% of the participants who reported in this survey that they had been diagnosed with a mental health illness prior to enrollment in the CR state reported that their mental health distress was at a minimum level once they became part of the collegiate recovery community. And I think that those two things are incredibly significant in terms of speaking to the success of these programs and the need for these programs in that particular venue. The next part 3 of the presentation, is about the sustainability and costs and replication. In that next slide, Carmen, we begin to look at what does it take to do these programs, what does it take to put them together, and part of what we find is that they're reasonable in terms of setting up, they're reasonable in terms of replicating, and I don't know if you can move this because I'm stuck on the one I'm on, but replication program has been able to establish universities around the country. I think we have 12 that are currently fully operational, and we have 30 or 40 in the pipeline of developing. There we go, sustainability and cost. And if you'll go ahead and just flip through to the next ones, I think we can have a sense of, and even the next one, a sense of some of the numbers. Those are some of the established programs, and then the next slide, Carmen, should show some of the replication programs and the areas that we have been able to do this around the country. There are more than we can really keep up with oftentimes in terms of requests, and I think that speaks a lot for what the universities are experiencing in terms of need. And then, Carmen, one more slide, and I'm going to be able to be finished in time. Best practices, I think that part of what we've been able to really focus on are the areas of social support, what are really needed, emotional, instrumental affiliation, and informational support for college students. And then a real clear statement of what the recovery community culture is. We use what we call the 4 C's, clean, sober, and healthy, connected in community, committed to academics, and civility and relationships. And I think with those things in mind, what we're able to do is really provide an ongoing system of support for these students that have chosen recovery and chosen also to receive an education at some of the greatest colleges and universities in the country. So thank you so much. I appreciate your interest in this, and know that we are going forward at a very, very rapid speed, which I find incredibly exciting. Thank you.
Thank you so much, Kitty. And thank you for all of our speakers' information today. Due to time factors, we are going to take a couple Q&A. If people have anything to add, they can do that on the right side in the chat box. In the event that we don't get to your question today, don't fear. We will answer your question directly offline via the email address that you provided us at registration. So if you do have a question after the fact, or just type it in right now in that Q&A box, and if we don't get to you now, we will be able to answer you offline. We don't have any questions quite yet, although we did have one earlier about when the latest strategy from the ONDCP, when that was released. And Peter, if you're still on, did you want to answer that?
Sure. This is Peter Gomon from the Office of National Drug Control Strategy, and National Drug Control Policy. And the most recent National Drug Control Strategy was released last week, April 17th. And if you go to the White House website, look up the Office of National Drug Control Policy, you'll be able to download a PDF copy of that report. We also have it available here, so we could email it to participants in the call.
Great. Thank you very much. I have not seen any more questions from the Q&A box on the right.
This is Peter. I saw one just a little while back that for David, and I think that I could maybe have 2 cents worth on it too, was about recovery supports only, was the way I understood it, versus treatment. Is that okay? And I don't think it's possible to make a blanket statement on that. What I will say is that we do know that some people have success with recovery support services only. For some people, we certainly wouldn't necessarily recommend that as the pathway, and I don't know if, David, you have anything to add on that.
Actually, I have no experience in that, so I'd rather not comment.
Exactly. So, and again, that's an area where we don't have a lot of research. We do know that, in fact, people do follow that pathway. We don't yet know for whom that seems to work and for whom it doesn't.
Great. Are there any other comments from any of the speakers that they'd like to include right now?
Well, I did see, and I typed it in the chat room, I'm not sure who saw that, but the comment about state support for high school and college programs. I am aware that there, in Massachusetts, there has been state legislation for funding of recovery high school programs, and that's been around for a few years. They actually just re-upped it last year. And I know in Minnesota, it's actually written into their education code about the area learning centers that it allows for alternative schools to support students with substance use disorders. So I know in those 2 states, they've actually got things that have gone through state legislatures. I can't speak as directly on the collegiate program level, but I do know for high schools, those are 2 examples. I don't know if Kitty knows about any college in states that have done stuff for colleges.
Yeah, and I don't think there has been any. I think that there's been some support, mostly through the legislature, just in some of actually the boards of regents and boards of trustees that have encouraged the legislatures to consider that. But as of this point, I'm not aware of any for the college programs.
Thank you, Kitty. This is Carmen from NCSL, and there may be mechanisms for colleges and universities to fund them kind of in-house, so to speak, and maybe not get a particular line item from the legislature from their funding.
Yeah, I think all of the ones that we've worked with have been funded in-house. We certainly are, mostly private foundations and private donors. And really what we found across the board, there's actually been not a lot of support from the universities themselves. A lot of the programs are funded through foundations and private donations.
Good to know. So it sounds like there's quite a bit of cooperation opportunity for private sector and private funding sources with the state schools.
Yeah, I think it's a great opportunity for public-private partnerships.
All right. Well, thank you, everyone, for attending the webinar today. We'll leave this Q&A chat box up for another minute or 2. If you have any last-minute questions that you would like our speakers to answer offline for you. And we hope that this experience has given you some information about educational settings for students in recovery. I'd like to thank all of our speakers today. And we put a link on the screen right there to a short survey that we'd appreciate it if you could take the time to give us some feedback. And we all hope to see you on future webinars. Thanks again, everyone, and have a great day.